So welcome everyone to our webinar on screening for broadband access and digital literacy in public housing patients. So first we're going to get started with some housekeeping instructions. All participants are muted upon entry. If you're able to, please try to turn on your cameras. Make sure that if you have any questions or you would like to provide any input or any comments, to do that through the chat. Raise your hand if you would like to be unmuted also throughout the presentation. And the webinar is also being recorded. The slides and recording link will be sent via email within a week after today's session as well. Today we have the honor of having these really great presenters. We have Dr. Jose Leon, who is our Chief Medical Officer for the National Center for Health and Public Housing. And we also have Howard Chapman, who is the Director of Programs and Development for Tri-Area Community Health. So more information about Howard Chapman. He has over 42 years of experience in healthcare management in rural community health centers in Virginia. He has served as Director of Programs and Development for Tri-Area Community Health since 2011, with the responsibilities of grant writing and reporting plus program development. And previously, Howard was the finance manager for Southwest Virginia Community Health Systems in Southville, Virginia. He has been an executive, he was also an executive director with supervising and managing the overall operations. His on-the-job training established a working knowledge of CHC operations. He grew SVCHS from a single physician practice with 6 employees and an annual budget of over $180,000 to a multi-site network with 6 medical behavioral health sites. A 15-chair regional dental center, the Migrant Health Network serving 8 counties, and a medication assistance program serving the PD3 area. The employees also grew to over 130, and the annual budget grew to over $9 million annually. So in areas of high need and few resources, his focus is on collaboration to serve more people. He has been an innovator and leader on the local, regional, and state level. He has testified before Congress twice and been invited to the White House for healthcare discussions. He has promoted telemedicine for over 22 years in rural Southwest Virginia. He currently serves on the board of directors for the Virginia Telehealth Network, the UVA Cancer Center Community Advisory Board, the UVA Cancer Center Without Walls Advisory Board as co-chair for PD3, the Virginia Diabetes Council Board of Directors, the Southwest Virginia Graduate Medical Education Consortium Board of Directors, and the Southwestern Virginia Rural AAPCHO Board of Directors. Howard holds a BA in Business Administration from King University. So about the National Center for Health and Public Housing, we are supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services, and is 100% financed by this grant. This information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. The mission of NCHPH, or the National Center for Health and Public Housing, is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. So before we get started with the presentation, here are just a few announcements from NCHPH. Please make sure to visit our website at nchph.org. And take a look at our newest publication, Healthy Together, a toolkit for health center collaborations with HUD-assisted housing and community-based organizations. And we also have an upcoming webinar on Wednesday, June 22nd on COVID-19 Look Back Forward, Health and Public Housing Listening Sessions. If you'd like to register, the registration link will be provided for you in the slide deck. And without further ado, I'm going to pass it on to Dr. Jose Leon.
Thank you, Fide, and good afternoon or good morning to you, depending on where you are in the country. It's such a great pleasure to be part of this conversation. Today we have a nice agenda on digital literacy. We're going to discuss the importance of screening for digital health literacy and broadband access in health center patients. We are going to list potential screening tools to assess digital health literacy and broadband access in health center patients. And we're going to explore how health centers can help patients with low digital health literacy during virtual visits. Next slide. Just to get a better understanding on digital literacy and what you're doing on this particular issue, we have two poll questions. Fide, can you please go ahead with the poll questions?
Sure.
So our first question is your health center assessing digital literacy? This is a very easy yes, no question. And if your answer for the first question is yes, what tools do you use? Federal tools, state health department tools, health center tools, those that have been created by your health center, or other tools. There are some organizations like AARC, for instance, that even though it's a federal agency, they work with other organizations to make sure that there are some resources for community health centers. If by any reason you respond to the second question and your response is other, you can also use the chat box or the Q&A feature to let us know what tools you are using.
Okay. So in terms of the results, we have 14% of respondents said yes, they are assessing digital literacy, and 86% said no. For the second question, 14% are using health center tools and 86% are using other tools. And again, if you're using another tool, please make sure to share what other tool you're using in the chat. Okay.
All right, we can move on where we have some really good materials, but thank you so much for responding to the two questions. And if you have anything else that you would like to share with us, please feel free to do it. You know, you can use again the chat feature on the Q&A feature. Next slide. So the National Center for Health in Public Housing provides training and technical assistance to community health centers in general. According to 2020 UDS data, in 2020, there were almost 1,400 community health centers providing services to almost 29 million patients. 435 health centers reported to be in or immediately accessible to public housing, and they serve 5.1 million patients. And 100 of these 435 health centers are public housing primary care grantees, and in 2020 they provided services to almost 900,000 patients. Next slide. Health literacy has been an issue that we've been discussing in many of the training activities that we have been doing through the last few years, specifically now with COVID-19, that we had an increase in the number of virtual visits. So we have already discussed the teach back method, for instance, and it's really important to know the demographics of this special population, because you will be, at the end of the webinar, you will understand why it's so important to assess digital literacy in this particular population. One of the main issues in public housing is that 35% of those living in public housing are at least, are 65 years or older, and around 38% of the public housing households report to have at least one person with a disability, and 55% of the households also report that they have those living in public housing have less than a high school diploma. So it's extremely important just to make sure that we understand that these are some limitations for those attending virtual visits when you are having conversation with your patients on different chronic medical conditions, diabetes or cardiovascular diseases or asthma, even if you are screening for some of the cancers like prostate cancer or cervical cancer, lung cancer. So making sure that you are providing the information that the patient needs, that the patients need, but at the same time, making sure that they understand what you are talking and what you are discussing with them. Next slide. The Centers for Disease Control and the U.S. Department of Housing and Urban Development have been working together trying to get very accurate numbers on what conditions are affecting all HUD-assisted adults. As you can see, this population is being affected by some conditions such as diabetes, COPD, asthma, disability. They report to be overweight or obese, and over 35% say that they have fair or poor health. Extremely important just to make sure that we understand the chronic conditions and all the health issues affecting public housing residents. Next slide. So we are going to talk about telehealth for a moment, and we know that there has been an increase in the use of these tools and these different platforms that we have available. And before the pandemic, before 2019, according to the American Academy of Family Practitioners, 14 to 28% of clinicians reported telemedicine visits. However, in 2022, 60 to 90% of clinicians reported telemedicine visits. So what is going to happen with telemedicine? According to the same publication, there are 3 factors that are going to affect how we are going to be able to communicate with patients virtually. One is the human factor, whether or not we are going to have the staff that we need to provide that service. From the patient perspective, whether or not patients are willing to have virtual visits. There are some patients who are not either familiar with the technology or who don't like the virtual visits. They prefer to go to the clinics and have an in-person visit. The other factor is economic factor, and who is going to be paying for the services, and whether or not there will be an increase in reimbursement or not. And the technology is also an issue. There are several platforms. People are using different technology platforms or features, from just a telephone, Google chats and and other that are more complex and very focused on health and how you can incorporate electronic health records and get all that information from the conversation you're having with your patients. Next slide. Some of the potential uses is that, first of all, you can maintain continuity of care. This is extremely important when you have situations like the one that we are living right now. The pandemic has been a big concern on how you communicate with your patients. It was a big concern in the very beginning. And at the same time, it's not the only one that it can affect our patients. We've been having conversation with health centers in Puerto Rico, for instance, during hurricanes or earthquakes or any other natural disaster. It's extremely important for health centers to keep, and maintain the continuity of care. And telemedicine has proved to be a great tool to communicate with our patients during these situations or emergencies. It also increased access for patients with mobility challenges. This is related to what we just discussed. About 38%, for instance, living in public housing report to have at least one person with a disability. So for some patients who have a disability, telemedicine or telehealth is a tool for them to keep the continuity of care and communicate with their providers. Is a great way to connect with patients and with service provider faster in many cases than traditional services. Offer coaching and support for chronic conditions. We can have a team, specifically when we are discussing team-based care, and you can have outreach people or nutritionists or behavioral health specialists talking to your patients. So this is extremely important when you have a patient with chronic medical conditions that who need different approaches and different treatment or protocols. Is at the same time is really important for healthcare providers to follow up with patients, specifically if your patient has been hospitalized. Let's say that your patient had COVID or any other condition, and you need to, and then they are back home, so and you're trying to talk to them and see, and get additional information for them. You also allow care teams, including the patient and their team of healthcare providers, to monitor clinical measurements and deliver ongoing training. This is also extremely important when you are having, for instance, communication with the specialists. You have your team of clinicians in your health center, but at the same time, you would like to talk to someone, who is probably a professor in a university or somewhere else, who is going to provide additional advice to your patient or to your team, making sure that the patient receives the best care and the best services. Next slide. There are some challenges as well, and you may list different challenges, but according to different resources like the Administration of Healthcare Research and Quality, for instance, some patients don't like, the virtual visit, and they prefer in-person consultations. This is very prevalent in seniors who prefer to go to the clinic, have a conversation with the provider. Some of them have limited access to technological devices. In public housing, we are going to see some numbers and some initiatives that HUD is doing in regards to internet access for some patients. The confidentiality issues is also important, specifically when you have patients who, by any reason, they are going to need an interpreter, for instance, or someone who needs to be with them when you are discussing any of the chronic issues or conditions affecting your patients. And the regulations of telehealth services by state, another big concern, and this is not equal for all states, so there will be some nuances there that we can discuss later. Next slide. Why is important to screen for digital health literacy? There are several studies on this, and at this moment, we are moving from the in-person visits to a more virtual environment. And if people cannot people cannot use a computer or do not have access to the internet, for instance, that is considered now a super determinant of health, according to some of the organizations dealing with this particular issue. The other concern or the other importance, something that we need to keep in mind, and the reason why we need to screen for digital health literacy is that 16% of adults 16 to 65 are not digitally literate. So another thing that we need to make sure that we address, 11% of white and 22% of blacks were considered not digitally literate. So there is a racial aspect that we also need to consider, and I am assuming that even though it's not here, is the same for other minorities like Asians or the Latino population. And then the age-related challenges as well. We've been discussing that people who are seniors or over the age of 65 are more likely to have some issues when it comes to how to use computer and other platforms to communicate with the providers. Next slide. Again, there is some issues regarding income based on some surveys. Only 56% of adults earning less than $30,000 per year have access to broadband internet at home versus 94% for upper income families. And when considering devices such as computer, phones, or tablets, only 18% of low-income adults have a device that can access the internet. So our first slide was an overview of some of the social determinants of health and some of the demographics affecting public housing residents. And Howard is going to also talk about rural population or populations in rural areas that also have this particular issue. Next slide. There are several resources, and even though these are screenshots and probably hard to read for some of us, we are going to share all these resources and the links so you can have access. And that's one of the reasons why we asked the first question, or one of the questions was whether or not you were assessing digital literacy. Again, there are some organizations like ARC providing some really good resources to assess telehealth consent and literacy. This is just an example on how you can assess whether or not the patient understand the instructions that you are given on how to use the internet. Next slide. This is something regarding the screening for digital health literacy and broad access in health center patients. All this information is in regards to public housing residents and what HUD is doing. You can find information on the HUD website, www.hud.gov, in regards to some of the initiatives they have to make sure that patients, although those living in public housing, have access to the internet. and at the same time have access to their doctors through virtual visits. Next slide. This is another tool that we are planning to share in regards to telehealth and making sure that patients understand what telehealth is and how telehealth helps your patients, and another way to assess whether or not patient will be able to understand all the instructions that you are giving them. All these resources will be shared with you via email with the slides and the link to the recording for this webinar. But we are just showing the different kind of resources that we have available for our patients. Next slide. This is part of the same questionnaire in regards to the frequently asked question by patients, and so they have a better understanding on telehealth and telemedicine. You know, these two terms are a bit different, and sometimes even providers have some issues understanding the difference between telehealth or telemedicine, and as you can imagine, patients also have the same kind of misunderstandings. Next slide. Same part of the screening tool to assess digital health literacy, and there is at the end of the form, you will see that the patient needs to write down their name and sign and add the date when they read all the information that you provided in regards to their digital health literacy. Next slide. Another resource from ARC in regards to whether or not patients are able to understand what the instructions and what they need to do. Again, all these resources will be shared with you via email at the end of the webinar. Next slide. This is another way to assess digital literacy and whether or not the patient is someone who is a candidate to get a virtual visit, or if it's better for the patient to go to the health center and have an in-person visit. This is a really nice tool as well that you can have, specifically if you are providing, you are assessing digital literacy. And again, we're sharing all this information with all of you. Thank you. Next slide. Yeah. So now it's my pleasure to turn it over to Howard Chapman. He's been doing all these kind of activities with tri-area community health, and he is going to share his experience with screening for digital health literacy. So take it away, Howard.
Thanks, Dr. Thanks, Dr. Leon. Good afternoon. Next slide. Tri-area is a small 5-site FQHC. We serve Carroll, Floyd, Franklin, Grayson, and Patrick counties in the Blue Ridge Mountains of Southwest Virginia. Tri-area has 2 full retail service pharmacies. It's part of our area is part of the economically depressed Appalachian region. So when you talk about some of those economic factors, we're definitely in low income brackets here in this service area. We serve about 10,000 patients with around 35 patient visits a year. We have around 115 employees. We've added a lot of employees since COVID epidemic. And we have about 18 medical and behavioral health providers. Tri-area is an NCQA level 3 recognized patient-centered medical home. So next slide. This is our service area map. And if you look in the lower left-hand corner where it shows the state of Virginia, we're probably about an hour, and maybe just over an hour from the Blacksburg area, the Roanoke area, maybe an hour and a half to down in Bristol, Tennessee, about 2 hours from Charlotte, North Carolina. But you know, we have several bordering states that, especially North Carolina, that we refer a lot of patients to. Next slide. Our sites, Laurel Fork site is in Carroll County. Floyd site is in Floyd County. The Ferrum site is in Franklin County, and it's right next to Ferrum College. So we get to serve most of those college students, at least during the school year. Our Grayson Highlands site is in Grayson County, which actually has the two highest mountain ranges in Virginia, a little over 5,000 square feet or 5,000 feet in elevation. So again, they typically have a lot of visitors for the national park that's up there, and then a Virginia Creeper Trail that with bicycles and things too. Our corporate office was the initial site that served up until about 2004, and now it's just mostly our corporate office. And in Patrick County is actually a collaboration between Patrick County Family Practice and Caring Hearts Free Clinic. And we have a behavioral health provider that accepts referrals and serves the behavioral health needs for patients in Patrick County. Next slide. I think Dr. Leon actually had asked us to be part of this based on a June 2021 publication by the National Association of Community Health Centers on Community Health Centers Telehealth Promising Practices. We were one of the 10 practices located in that. Next slide. And our program was a diabetes quality improvement program that focused on uncontrolled diabetic patients with a hemoglobin A1C of 8 or greater. We use an endocrinologist from UVA, and endocrinologists are really tough to come by here in Southwest Virginia, but he follows the patients for 6 months with a real sort of a self-motivated self-management program. And we couple that with using certified diabetes education classes, and typically the local hospitals are charging for those somewhere between $30 to some up to $80 for, and somebody can't afford to buy their medicines. It's tough to for them to justify paying for the education component. But UVA has been able to offer those through telemedicine link or telehealth link, and we can do them on site for patients for free. So it's a great opportunity. This project focuses on using a home monitor to measure blood glucose, dietary intake, physical activity. They also have digital devices to do pulse ox, digital scales for weight, and blood pressure monitoring. All this information is uploaded, and the initial intent was to have it go to the meter and then be uploaded automatically to the a secure cloud, but that didn't work out in our area. A lot of the areas did not have a sufficient Wi-Fi signal or broadband, so the device we settled on sends a low frequency signal to your smartphone, and then when you hit a Wi-Fi signal, it uploads that information in chronological order so that, again, it can be accessed by the endocrinologist, the patient, tri-area providers, nurses, case managers, and other healthcare or part of the healthcare team with secure password clearance. Next slide. Here's some results of that initial assessment on doing this. So on average, the endocrinologist, through a 6-month program for the folks that complete that program, the average hemoglobin A1C coming in is a 9.9, and on completion of the program, it's dropped to a 7.7. So it's 2.2 points over the 6-month period. And if you'll notice on the little graph, there's some that go from up around 11 or 12 down to below 6. And so he's done pretty remarkable work at doing that. Next slide. This is FCC Commissioner Brandon Carr held a press conference at our Tri-Area Laurel Fork site to announce the FCC Connect Care pilot grant for $100 million in June of 2019. And he wanted to do that in a rural area and with a program that actually had some proven success. So he called and actually wanted to come out and do that press conference there at Laurel Fork. And we actually connected to UVA and had them part of that process, since Dr. Santon is actually the UVA employed endocrinologist. And one woman at that event actually gave her testimony, and coming to Dr. Santon, she had a hemoglobin A1C of greater than 15, and he lowered it to below an 8 in the 6-month period that with that self-management program. Next slide. Again, some of the different types of telemedicine, telehealth. The synchronous are the live and real time. And so we have access to 24 separate specialties at UVA. And UVA has a sliding fee program through their charity care that allows patients to, our uninsured patients, to be seen based on their ability to pay. They do provider and staff CME through the telemedicine or telehealth. They provide patient education, and we have again a certified diabetes education class that locally they'd have to pay at least $30 for that, and we can do it for free. Diabetes quality improvement program, again with Dr. Santon, and the results of what he's been able to do with their diabetic patients. We do site-to-site consultations, primarily with our behavioral health providers. We do have a part-time psychiatrist that we can actually link that for patients that need that. So it's become an important part of what we do. The asynchronous or store and forward, UVA has a contract with all the community health centers in Virginia, or most all the community health centers in Virginia, to do x-ray interpretations. And at one point in time, doing these by mail and other means, it would take a week or longer to get x-ray interpretation back. Now we get them back the next day, and we can actually get stat readings for patients in certain emergencies and things. We do the digital retinopathy screenings, which is part of the treatment protocol for treating the diabetic patients. And when we first started this, 40% of the patients said that's the first screening they'd ever had. So we're able to provide that aspect of their treatment for diabetes. And the director for the ophthalmology program there actually wanted to do that and get the results back within 20 minutes. So he wanted it, and it had to go through FDA approval to use his iPad and smartphone to get those images sent to him so he could do the interpretation. And usually that was the ability for us to schedule the patient for follow-up care before they ever left our building. So next slide. These are the 24 separate specialties we have access to through the University of Virginia. Next slide. The benefits to community health centers, it removes a lot of the rural isolation and makes it easier to recruit and retain physicians. It improves the compliance for being with patient-centered medical home. It improves the improved patient access and to specialty care. Again, some of the, in our area, there's a shortage of primary care providers, but there's a greater shortage of specialty providers. And in some cases, patients were being asked to pay that money up front, and it's money they didn't have. And so with the charity program through the University of Virginia, we're able to get those patients to go ahead and do their follow-up visit. And it's nice to be able to get those results back. So improve patient compliance again with treatment plans, and then improved coordination of care. Next slide. The things that affect telehealth are human and technology resources. A camera and monitor and cart setup is probably under $12,000 now. I think I've had our IT guys say it's probably $8,000 to $10,000. And 20 years ago, that was probably $75,000 for that setup. You really need to have good connectivity, 25 megabits per second or greater. But we got by with far less than that based on the fact that UVA was able to come in and sort of reserve space in our router so that we didn't get bumped off from a telehealth visitor in the middle of a telehealth visit. You know, Universal Services Administration actually provides up to a 65% discount to qualified organizations, which makes the ability to afford that broadband a lot more affordable in a community health center setting. You have to use a system that's a secure network and maintain HIPAA requirements. We would recommend too that you have well-trained staff. There's a certification program like STAR that was modeled after programs in Alaska where they use a lot of telemedicine. But if you've got somebody that actually knows the program and able to troubleshoot, it helps out not only with the telehealth visit, but it also helps find the problems and issues with the patient on their end too. So it keeps things moving fairly smooth. And then having a provider champion and support from senior management. If you don't have that, it's really tough to get a telehealth program, telemedicine program off the ground. Next slide. The telehealth resource centers, these are HRSA funded telehealth resource centers, and they're an excellent source for providing education and to organizations and individuals interested in telemedicine and telehealth and other health technologies. They link interested providers and healthcare facilities to programs that are successful programs and are using telemedicine. They provide technical assistance and an array of trainings to get the programs up and running. They work to identify and target regional needs in their service area. And I have a great working relationship with the Mid-Atlantic Telehealth Resource Center Director, Kathy Weberling, and her staff. She's actually included me on a FQHC focus group that has 6 the Telehealth Resource Center directors and FQHCs involved in ongoing discussions and trainings. Next slide. Policies and issues. One of the things that community health centers face is, again, it's a definition issue from CMS, and it dates back to 2014. And to serve as a distance site, you have to be a physician or a practitioner. And their definition is, since the definition of physician nor the definition of practitioner includes RHC or FQHCs, we do not believe that a rural health clinic or an FQHC are authorized in this statute to be a distance site. And that means that for at least our Medicare patients that are on CMS, once this executive order is lifted, I think we have 120 days that they will carry on and allow us to be able to. And we've been arguing this with in Congress and trying to get that corrected for several years now. But you know, many commercial insurance carriers default to whatever the CMS standards and policies are. You know, and even HRSA back through 2018, they did not count any medical visits that were done through telemedicine and telehealth. In 2019, they started picking up and allowing you to count those. And people usually won't do things if you don't get credit for what you're doing. So next slide. Telemedicine and state regulations. Again, state regulations are most of what regulate and drive telemedicine, telehealth programs. Telemedicine is defined as using technology to diagnose, monitor, and treat patients remotely, and telehealth is applying technology to assist patients in the management of their illness through self-management and access to education and supportive services or systems. We already talked about synchronous being the real-time and interactive audio and video, and asynchronous being the store and forward of data. So Next slide. And Virginia telehealth regulations, they implemented a parity law that mandates equivalent coverage for telemedicine and in-person services for private payers, Medicaid, and state employee plans. State mandates reimbursement only for medical services provided via live video and other limited coverage for other telehealth applications. Tri-area is paid for telemedicine services even as a distance site through Medicaid and through most commercial plans. Next slide. Issues around poor connectivity and broadband in rural Southwest Virginia. Again, we use the Universal Services Administration discount to bid our services out. And our current USAC supplier vendor for broadband in our current contract for Laurel Fork and Grayson County was supposed to move us up to 100 megabits per second, but they were unable to do that. So we're back to revising that contract. We do have 50 megabits per second at Laurel Fork and our Grayson County site, and 100 megabits per second at our Floyd site, 20 megabits per second at the other sites and the corporate office. And again, in a comparison from 2 years ago, we had 10 megabits per second at the Laurel Fork site, 6 megabits per second at the Floyd site, and 3 megabits per second at the Fairham corporate office. So you can see there's been a pretty substantial increase in our broadband connectivity. And not only are you running that telemedicine, and like I say, we had UVA able to reserve space on a router, but you're competing with the EMR, the practice management system, emails, and internet for that broadband space. So next slide. Digital health literacy. In screening for digital health literacy, we actually ask how many patients have a smartphone, and we try to collect get their number at the time of registration. And all our Virginia Medicaid programs actually provide access to, in the PPO plans, to a free cell phone and service plan. We actually think that one of the ways to see who's actually using our digital connectivity is through the use of the patient portal. And in 2019, we had a little over 7,000 logins. In 2020, that more than doubled. It went to over 14,000 logins. And 2021, it was over 23,800, almost 24,000 logins. So there's been a substantial increase in doing that. Tri-area staff and Dr. Santon actually help the patient with their knowledge and introduction to the education on the devices that they'll be using for the home monitoring. Next slide. Some of the tech checks. We have a new telehealth coordinator that will work with first-time telehealth patients to be sure they understand and have appropriate equipment and broadband any devices provided usually are locked and restricted to improve access and security, make certain they're not on risky sites. They even educate them on some of the etiquette about not have kids playing in the background and TV playing in the background, not to connect at McDonald's. You really need to assure that it's private and quiet space for a telehealth visit. Engine is a contracting firm that we use that does some assist with the analysis, the integration, and operation in rural areas. And the UVA team, they assist patients with the devices and connectivity that they supply. And typically on some of these things, they're actually sending out a tablet with patients that they may be following in addition to some of the tri-area staff too. Next slide. Again, knowledgeable staff, the STAR program, again, with somebody that's gone through that certification program, they can troubleshoot for any technical issues. UVA offers a variety of trainings based on your discipline, and physician and even some of the specialty providers, they go through that training in order to conduct and provide a better telehealth visit. UVA's trainings are online. They provide patient with good orientation for the device and equipment prior to a telehealth visit. And that's pretty much it for me. My contact information is on the next slide. Just a couple other projects that we're working on right now. The Patrick County lost a critical access hospital in 2017 and lost all but 2 family practice physicians that stayed there. They brought on more nurse practitioners to help them meet some of the patients' need, but it's a county of about 18,000 people. We're currently working with UVA and some other FQHCs on the HRSA accelerating cancer screenings to be able to reach out in their community and do some advanced cancer screenings. And also with UVA and other FQHCs on an FCC grant for yet another chronic disease management and home monitoring program. And we think this one's going to be on cardiovascular. So those grants are in the works right now.
Thank you, Howard. Thank you for sharing your experience and your program and everything that TRICARE is doing, to help patients through all these digital process. I mean, we are all learning. This is an ongoing activity, and we have new resources, new apps, and we appreciate what Tri-Area Community Health Center is doing. Thank you so much. So if you have any questions or anything that you would like to ask either to Howard or me, please feel free to either use the Q&A feature or the chat feature, or if you would like to ask your question verbally, you can also use the raise hand feature icon at the bottom of your screen, and your line will be unmuted. So we're going to give some seconds in case we have any questions. I just want to remind people about the activity that we shared in the very beginning, the activity that we are doing with HUD and HRSA on collaborations and partnerships between public housing agencies and health centers. We are very happy to announce that Jim McCrae will also be part of these conversations. So if you would like to get any questions or anything that you would like to get from this conversation, make sure that you have them ready. Fide, I see that there is a question. Can you please read the question for me?
Sure. So the question is from Gary Williams. What eye examination tools do you use for telehealth?
For us, we use a digital retinopathy camera, and some of these have been scaled back now to like a little handheld camera, but we use something that is consistent and integrated with what the UVA. So it's the large mounted cameras, and again, it's amazing. A little bit of training to come in, sit down with your staff and do that. Then UVA basically serves as the quality and continuing quality improvement to make certain we're doing it right. If we've got problems or issues with the films, but so far it's been a great service for our diabetic patients.
Thank you, Howard. So in the meantime, also, I just need to remind the audience that at the end of this activity, there is a survey. So please make sure to complete the survey. Your information is very helpful and valuable for the National Center for Healthy Public Housing to improve our activities or get ideas on new topics that you would like to discuss. At the same time, remember that there are several organizations working on this particular issue. Howard mentioned the diabetes program that they have. And last month, the American Academy of Family Practitioners had a very interesting article on diabetes and telemedicine. And the results were very positive on how your interaction with your patients through telemedicine can really cause an impact on reducing the A1C in some patients with uncontrolled diabetes. So what we need to make sure is that our patients understand the instructions, that the patients have the internet access, and at the same time that they can use technology. You know, I mean, it's an extra step. Sometimes as providers, we forget that step, but we're making sure, you know, having someone who can explain patient how to use the technology that you have in place will help a lot. Patient will be able to better understand your instructions, your recommendations, and that's going to be that's going to improve any outcome, you know, for any of the chronic medical conditions affecting our patients. Any additional questions, Fide?
No additional questions.
I'd just like to say too, one thing is, you know, basically in Virginia, we've still been paid on a fee-for-service basis. We've seen very little of the value-based payments. But as those come around, if you can show through the outcomes that you've improved that patient's health status, that I think that's where some of the things in the end are going to be real rewards for some of the FQHCs that are using telehealth.
Excellent comment, Howard. Thank you so much. If you have any additional questions, or if you would like to get in contact with any of our staff members, next slide, Fide. These are our contact information. You can either contact our director or our communication specialist, or Fide, who is our research assistant, or you can also contact me through email, and we are going to be very honored to keep the conversation going with all of you. Thank you so much for your participation, and have a great afternoon. Thank you, Howard.
Yeah, thank you. Can I get you to send me the slides too?
Sure. We're going to get you the slides, and we're going to get you all the resources.
That will be great. Thanks, guys.
All right.
Yeah, appreciate you including me. Thanks.
Of course. Thank you so much.